Production funding for Behind the Headlines is made possible in part by the WKNO Production Fund, the WKNO Endowment Fund, and by viewers like you. Thank you.
Where Memphis stands in the fight against coronavirus. Tonight on Behind the Headlines. I'm Eric Barnes with the Daily Memphian. Thanks for joining us as we continue to do the show remotely. Today, we are joined by Dr. John McCullers, an infectious disease expert who is Dean of Clinical Affairs at the UT Medical School, as well as Pediatrician-in-Chief at Le Bonheur Children's Hospital. Dr. McCullers, thanks for joining us again.
Happy to be back with you, Eric.
Also, Bill Dries, reporter with the Daily Memphian. So, Dr. McCullers, we've had you on a number of times. You've been really gracious with your time. I think we had you on one of the last shows we did in the studio as things were starting to get, so that would have been March. And I listed some of your titles. You're also a part of the City-County COVID Task Force. You're part of the subcommittee of that group that is going through and looking at the reopening phases. At this point, what do you worry about? What number do you look at, or numbers do you look at, and what do you worry about as we continue this phased reopening?
Well, in terms of worry, I've been fairly comfortable for the last 6 to 8 weeks about where we are with our daily trends, our weekly trends, where we are with our capacity to deal with the potential to have a surge. The things that worry me are not so much where we're going day to day or week to week, but things like schools reopening and the winter coming and worrying about things that aren't in our control right now. Right now, I feel like we have things under reasonable control, but once we have to start sending kids back to school, or once winter comes and flu season starts, maybe we lose some of that control.
Some of the worst predictions, again, March seems like 100 years ago, but some of the worst predictions, there was the Imperial College study that I think you and I talked about on a podcast one time that talked about, millions, tens of millions plus dead in a worst case scenario in the United States. There were worst case scenarios here. We really haven't come even close to those worst case scenarios. And so it's a strange dynamic. You get a certain number of people who are saying, well, the models were wrong and we've overreacted. So from your point of view, were the models wrong and did we overreact?
Yeah, so I think there's two things to think about here. So what is it that models really can do? So the way these models are constructed, they're not very useful for asking a question like, what's going to happen 3 months from now? How many cases are we going to have 3 months from now? What they're useful for is these kind of if-then scenarios, right? So you can say, if we do this, or if we do this other thing, what's the relative difference in this? So if we do it this way, we see a lot more cases. If we do it this way, we see only a few more cases. So the models are really good at helping with choices and decision making, but not in giving you an exact number of what we're going to look like 3 months from now. So in terms of, we had those models, we were looking at them a couple of months ago. I said there's probably 3 possibilities that we're going to have. One is that we're not going to be able to control this and it's going to look like the model says. And the model was really a worst case scenario if we don't intervene. The second one was what everybody had been talking about, which was that flattening the curve. And that was the idea that we can't really stop it, but we can kind of push it back for a while. And that's going to allow us more time to get ready. And I think that was kind of the popular idea at the time. And the third one that I think I was pushing a little bit and wasn't very popular was the idea that we would just cut this off entirely and not get rid of it, but at least stop transmission or suppress it to a low level. And that's what really happened. Instead of flattening the curve, we've truncated the curve. We have reduced transmission to really negligible levels. It's still there, but it's not accelerating like it was before. And so unless we mess up, we're never going to have that surge that we were all talking about.
Okay, one more follow-up, and then I'll turn over to Bill, because you just kind of, that was a lot. That you think that truncating you think that whole idea of that surge, of that rebound, mean, again, it's hard to look into the crystal ball. I mean, you just talked very eloquently about the problems of models, but I guess maybe it's media folks and others want to know what's going to happen. But you just said you don't think there'll be a surge, even as we continue to reopen.
No, so right now we really do have an element of control, and it's dependent on the public. So the public has to be able to continue to do social distancing and wear masks and not get together in big gatherings that might accelerate it, right? But if we do those things, I'm very comfortable that we're going to be able to keep transmission at this, low, almost negligible level within the community. Now, what threatens that, right? And what threatens that is you do something like send all the kids back to school. That's something we have to do, but it presents risk that you're going to accelerate it and you're not going to be able to control it. It's going to get outside your capacity. What else might threaten it? Well, we get into the winter, we have flu season here. The hospitals are full because of flu and other, wintertime illnesses, and we can't manage COVID. So those are the things that, could disrupt the scenario. But as it is, we've attained a measure of control, and as long as we don't do anything to disrupt that, we're going to be able to continue to control it at some level.
Bill.
Doctor, for several days, for more than a week, we have had the phenomenon of hundreds of people marching, as of last night as we tape this show, marching in different parts of the city. The marches began in downtown. When you look at that from this pandemic perspective, are there concerns about what that could do to the curve?
Yeah, I think from the public health standpoint and the pandemic perspective, anytime we have groups getting together, that's worrisome to me that we're going to see more cases occur. We're going to see this, accelerate the pandemic just because there's more points of social contact. Now, the other side of that is first of all, this was really an important, critical thing for us to be doing. I think the protests were incredibly important, and the consequences notwithstanding, that was something that we had to do as a society. And we may have to deal with it, but again, I think if we see a surge of cases for a week or two that are based on this, but we're able to maintain our control and our capacity, is something that we can weather. And maybe it's a little bit of a harbinger of what might happen in the fall when kids go back to school. The other two things I think about, though, are that for the most part, the protesters and the marchers were wearing masks. I think certainly Memphis has done a better job with this than many other places. And if you looked at those crowds, and I had a daughter marching, so I was getting reports, most people were trying to be responsible and were wearing masks. And the second is, this is predominantly, not completely, but predominantly younger people who are at less risk for having severe disease or death from it. So if you want to have one demographic that's out marching, younger people would probably be it.
Mm-hmm. The timing for this pandemic has included several holidays, several cherished days: Mother's Day, Memorial Day, Easter, Passover, have all come within the time frame of this pandemic. Has that given you some more indicators, or has it really given us more challenge in this?
Yeah, well, what we've generally seen is on the weekends when the weather is nice, and certainly on the holiday weekends where you have an extra day where the weather is nice, we do see our indicators of social distancing and of people clustering tend to rise a little bit and to come back down during the week. And we do see some fluctuation in caseloads, and that we tend to see more cases a week or a week and a half after those long weekends, particularly when the weather is good and people are likely to be out. But to this point, it's been fairly cyclical, that it may go up a little bit, but then it's going to come back down because, again, we have this measure of control. So again, it's something that we do worry about. We talk about the same way we worry about, the protests and the people getting together. July 4th is coming up. That's on a Saturday, so we know that's going to be another weekend where we might have a little surge in cases. But overall, the pattern has remained stable, that we've come back down after those weekends and kind of reestablished that baseline.
And before we go back to Eric, now that we have testing up to a certain level, certainly at a higher number than we did at the beginning of the pandemic, what is the effect that has on watching those bumps in the numbers for positive cases? What does that tell you that you didn't know before?
Yeah, it was very interesting. You know, early in April, we clearly did not have enough testing. We were missing a lot of cases. We knew it. And so it was very difficult to interpret the numbers because we knew there was just a lot of people out there who were not being tested. Once we reached a level where we really thought we had both sufficient quantity of testing and really a distribution across the county so that we had equal access to testing across the county, then we began to feel more comfortable in what the numbers really meant. And we are at a point now where I feel like, at least for the level of the cases we have right now, and if we were even to double or triple, that we have sufficient testing to do it. We still have some challenges in the geographic distribution. As one example, we opened a new testing site this past weekend in an underserved area of the county where we really hadn't had a lot of access to testing. And that spike that we saw on Tuesday with 190 cases, many of those were from this one neighborhood that we had just not had access to testing before, and we found a large number of cases there. So I think some of the spikes we see are when we do kind of penetrate into areas we haven't had testing before. Some of them are clearly related to some of our surge testing in prisons or in nursing homes where we know there are positive cases, and it's kind of difficult to subtract some of those peaks and try to figure out what the baseline is when you have this noise in it from these campaigns we're doing to investigate where we're seeing a number of cases.
How much how much testing should be happening of people who don't have symptoms? Because a lot of the testing, like you're talking about in nursing homes, those are kind of hot spots, but just almost randomized testing of people, given that the capacity, we're really underutilizing our capacity right now, if I understand correctly. How much more randomized, almost asymptomatic testing should be going on?
Yeah, so it's a difficult question, and it's one we've struggled with for probably the last 4 to 6 weeks, and that's who should be tested, under what circumstances should we be doing testing of asymptomatic persons. And there's a couple of issues with that. The first is that this is really an imperfect test. The way this test works is if you have a very high prevalence of disease, so most of the people have disease. So for instance, if you're testing in a hospital, sick people who look like they have COVID, the test really works pretty well and you can rely on it. If it says it's positive, it's probably positive. If it says it's negative, it's probably negative. When you start testing the general population where the prevalence is very low, so maybe 1 in 200 people or less are infected, the test doesn't work as well. We start to see a lot more what we call false positives, where it may be positive and they're not infected, because the test does tend to have a false positive rate. And if many people don't have it, then the false positives tend to stand out there. So that's one issue that we see, that you get into some trouble using it in a population where the prevalence is low. So we've tended to point towards strategies where you're going to have a better chance of detecting infections. So frontline healthcare workers. So we've been testing a lot of them, even if they're asymptomatic, just because we know they're more exposed. As we've started to have excess capacity, we've invited other frontline service workers. So we've opened up our testing and tried to encourage it in grocery store workers and restaurant workers, those who are interfacing with the public to some extent and might be exposed. And maybe they're more likely to be infected. The test is probably more likely to be accurate in that group. And then the third area we've really concentrated a lot on the last couple of weeks has been in businesses. And so businesses are trying to construct, how do they deal with reopening and how do they access testing? And that's one of those questions is, who are they going to target for testing? And is it those who are public facing, or is it those in critical areas who they can't afford to have positives, or is it everybody? There's a lot of expense with doing it, so the everybody hasn't tended to make a lot of sense.
And let's go to Bill.
And Doctor, what we hear in the daily briefings from the COVID task force continually is capacity for testing, and that people are not using all of the testing that's available out there. Why not? What are you hearing from people why they don't go get tested when they might have symptoms?
Right. So I think one issue is that we really do want to have excess capacity. So it's not a bad thing that we have all this capacity out there. We want to have that so if there is a surge, we're able to combat it. But at the same time, we also worry that we're missing people and that they're not coming out and getting tested when they should. And the capacity allows us to really reach out and say, hey, come, we can get you in easily. It's simple to get tested. Now, there's a couple of things out there that I think are preventing some people or discouraging some people from getting tested. The first is, when we first started this thing, everybody was very anxious, was very worried. This was new. There was a lot of, I need to go get tested immediately. And it's been weeks and some of that has died down and people aren't quite as worried about it, I think, as they have been before and don't feel that urgency to get tested, which again is not the message we want. We want everybody to get tested because it's important and because this is a really deadly disease. And the second is the word's gotten out there that it's an uncomfortable test. You have to put a swab into your nose. There's a little bit of pain with it sometimes. And some people that's enough of a barrier to say, well, maybe I don't really need to get tested today because I'm worried about the pain from the swab. And again, trying to get out there and combat that and say, hey, there is a little bit of discomfort, but it's not as bad as COVID, obviously. So we need to get you tested and know what's going on.
Are there different kinds of tests that we could see come into play here?
Yeah, so there's two different ways I look at that. Is we have some different testing modalities. So right now we're using a test that you have to send to a laboratory. It takes about 24 hours, sometimes longer, to get a result from it. There are some rapid tests that are out there right now that are being used in some settings, both in physician offices and in some of our community testing. They get a result in about 15 minutes, although if there's a line, then it may take a few hours. Now, the problem is they're not as accurate as the test. So you trade off the convenience and how quick it is for the accuracies, which is a problem, but it is a trade-off. The second is we typically are using what's called a nasopharyngeal swab, where you have to push a swab all the way through the nose and into the back of the pharynx, or the back of the throat. And that's why it's a little bit uncomfortable, is you have to get all the way back there with it. We can do now what's called a mid-nasal swab, which only goes about an inch into the nose instead of all the way through. You could use saliva for this. As you kind of go away from nasopharyngeal to mid-nasal to saliva, you lose a lot of the accuracy of the test. So again, we can make it more comfortable to really trade off your ability to get an accurate answer. And I think people mostly would rather have the right answer and have a little bit of discomfort.
And before I send it back to Eric, there has been talk here of setting a goal of maybe 30,000 tests a day. Is that the phase at which maybe people get tested several times once we ramp up to phase 3? Is that what we're talking about, a number that's that high?
Yeah, so I'd say we're still at the discussion phase about that right now. And that is really thinking about if we had to do mass testing, say in schools, if we had to do mass testing within businesses using the public health apparatus, well, obviously 3,000 tests a day, which is where we are right now roughly, probably isn't sufficient to do that. So we're exploring how can we ramp up our current infrastructure to do 30,000 a day, which would allow a lot of that. Now, the other way to do that would be to create other avenues for testing, maybe testing within certain large businesses in town, to really try to distribute testing across many different medical offices. This is something I'm working on. I'd love to have testing in every minor med and urgent care and many of the just typical medical offices like we get any other test. And if we're able to achieve that, then this won't become such of an urgency for the UT and the city and the commercial labs to carry that burden.
I will say I got tested. My daughter and I both got tested a week or two ago, and it was not for me. For people who are hesitating because they've heard it's painful, it was not painful. It was just wildly uncomfortable and strange. But it really wasn't painful. And for my daughter, it was. She had basically the same experience. I wanted to talk a little bit about, and we talked about this early on. And I remember you saying to me either on the podcast or on the show that. Yeah, we should shut everything down, but maybe we wouldn't. That people just wouldn't be willing to do it as long as they did. There's clearly evidence of some degree and I'm curious what you think of the emotional toll of this shutdown, of the isolation for people. One of the obvious ones you see it in is this, this huge spike in the overdose deaths. What's your measurement of that toll, the emotional, psychological kind of a toll on people?
So I've been very concerned since we started this of two things. One is kind of civil disobedience and people really reacting against this. And we have seen some of that around the country, but not as much as I was worried about. And I think Memphis has been a lot better than many other places. We've seen it in the protests as well. The protests have generally gone well here, have been peaceful, have been robust, but have been peaceful here. And I think our response to COVID similarly has been more community oriented and hasn't been as anti-authoritarian as some might have worried and as I might have worried about that particular issue.
One of those points on a national level that has gotten sort of political or politicized is masks. I'm not going to ask you to comment on the political side of it, but early on, I think a lot of people said, well, we think masks are effective. There's no downside. Please do it. Have we had more research in this really short period of time that feels so long that masks truly are effective, or is it really just a best practice at this point?
Yeah, so I think there has been a lot more research to come out. I do say we knew that masks were going to be helpful in this, and we were done a great disservice early on by federal officials, by the Attorney General, by the CDC, saying don't use masks, they don't have any utility, they're not going to prevent infection. That was clearly incorrect. It was done for political reasons and because we wanted to preserve masks for healthcare workers, and that was the wrong message. And many people to this day say, I'm not using a mask because you lied to me about this before. So that's a big problem for us, the reversal of the messaging. But it's also true that we're coming to see a lot more data come out, a lot more studies, scientific studies about the utility of masks. So the second sort of inaccuracy I'd like to point out is for a long time after we went back to, okay, there is some use for masks, it's been, you're wearing a mask to protect others, okay? Because it's gonna trap the particles that you're breathing out or coughing out or sneezing out and prevent you from infecting others. But the mask still isn't useful to protect you. And again, that's an inaccurate message and one that kind of goes against the psychology of the thing, right? So most of us, we may say we're going to be altruistic and wear a mask to protect others, but at the root cause, when you get to it, when you do the studies, the altruism doesn't change behavior very much. What changes behavior is, I don't want to get infected, so I'm going to wear a mask. And what we know now is that there is plenty of protection from these masks. The major impact may be on others, certainly within if there's a high prevalence of disease, but there is significant protection for you from others, particularly if it's in a short-term environment. If I walk in to a restaurant and I'm picking up takeout and I'm paying my bill, I'm in there for 5 minutes, that mask provides really solid protection. If I'm sitting around at a nail salon for an hour, maybe that mask doesn't help me very much just because of the time of exposure. But for that short-term, low-risk exposures, it really is very helpful. And we need to have that messaging that, yes, you're protecting yourself, you're also protecting others.
Well, another sort of tool that you all that have talked about is contact tracing. Again, as we move towards this reopening and things like you said, opening schools up and workplaces opening up, what is the status of contact tracing in the Memphis area?
So the contact tracing is done by the Shelby County Health Department. Early on, we clearly weren't able to keep up with all the cases. They have really, increased their workforce, and right now, at our current level, we're getting to 100% of them within 24 hours, which is our metric. So it's great right now. Now, the health department does have a plan right now. They're hiring another 141 people to do contact tracing over the next month. And again, that's to provide that extra capacity when we do get into the school year or in the winter. So I feel very comfortable about it right now, although it was a problem very early on.
Bill, with just a couple minutes left.
Are we ready to live with COVID-19 long term? Do we have, I guess, what you would call the infrastructure or the practices in place to live with this virus longer than just this outbreak or this pandemic?
I think we're at a point where we can manage the disease And I think long-term, we could continue to doing what we're doing and be kind of at this new pattern, this new normal, and control the disease. There's two concerns in that. The first is that we're clearly killing a number of small businesses. So restaurants can't survive in this new normal, and another other thing. So that's going to cause a major shift and a lot of problems down the road. The second piece of that is some of what Eric brought up earlier, which was the mental health and the addiction side of that. The longer we're kind of, put back into these this isolation type of protocol, the harder it is going to be to deal with all those issues. And right now we have a really major problem in that people are avoiding going to the physician, and particularly when we're talking about mental health and addiction, if you're out of contact with the medical professionals that are helping keep you straight, that's a major problem. And I'm very worried that one of the long-term issues we're going to see out of this is a spike in addiction and alcoholism and in mental health issues like depression, both because of the isolation and because of this limitation of getting into medical care.
All right. Well, there's more to that, but we are out of time. Dr. McCullers, thank you for joining us. And remember that you can get past episodes of Behind the Headlines on the WKNO.org website, or download them as a podcast from the Daily Memphian site, iTunes, Spotify, or wherever you get your podcasts. Thanks, and we'll see you next week.